Now, sleep is always challenging to the physician, and the staging of sleep and the EEG is always a challenge. Now, I wanted to point out that sleep staging is, although complex, is quite simple. And this has led ultimately to the classification of various sleep stages. Now, understanding sleep stages is particularly important because certain pathologies in sleep occur at different stages. Now, this is particularly true for the pediatrician. Now, just to focus on the elegance for a pediatric sleep doctor is that awake, when we do the EEG, we call it alpha activity. It just means very, very fast. And then when you go to sleep, close your eyes, it slows down. And then that's called stage 1. Now, what's the difference between stage 1 and stage 2? It is these, you see, things called sleep spindles. These are little squiggles of fast EEG waves, and then things called K complexes, up, down, just like this. Now, they are quite obvious. And then there's a third stage, and this is called delta sleep. And you see these big, huge waves, hence the name delta. Now, it used to be classified in stage 3 and 4, but we don't do that right now. If you have a delta sleep, you generally are in stage 3. Now, what we all know about is REM sleep. Now, REM sleep, again, faster, more erratic, but this is characterized by decreased muscle tone. Now, REM sleep is pretty important. It's pretty important through the rejuvenative part of sleep. But what's also intriguing, even from a pulmonary point of view, is that's when you're paralyzed. So most of us know this and says, oh, that's when you're paralyzed, and the diaphragm is the key muscle of breathing at this point. So what happens is not true paralysis, it just means that the muscles are inactive, and what you see is just a diaphragm moving. Hence, if you have lung disease, the only muscle that's working particularly well at that time for breathing is the diaphragm. So this is when you see problems with lung disease in the middle of the night. Now, just to show you, sleep goes through cycles. Most people are aware of these cycles, and most parents are. So you go awake, stage 1, stage 2, stage 3, stage 4. We don't do stage 4 anymore. 3 and 4 are the same, and then you go to REM. Now, literally, you can go from stage 2 to REM, you can go from stage 3 to REM, or vice versa. Now, the other item that you noticed is REM becomes more frequent as the night goes along. Now, REM, what is REM? It's a great name because of rapid eye movement. So you see rapid eye movement, and you see it late at night, in particular. Now, we have a particular interest in REM because remember I said it was rejuvenative. So with the usage of SSRIs or SNRIs, this reduces REM sleep, and hence may be partially the reason for the lack of rejuvenation while on these therapies. So we focus on this quite a bit. Early REM to us, with very, very early REM, suggest items like narcolepsy. Now, just to give you an idea, with age, you need less sleep. If you look early on, and also the thing that declines most is REM sleep. So this is all the way out to 30 years of age, and it extends all the way into later life. So you see, REM sleep is 50-50 at this point, and then you see the non-REM, that's stage 1, 2, 3, and stays roughly constant. So really, at 30 years of age, we need about 8 hours of sleep. Now, the newborn infant is always a challenge. So we need to focus on this a little bit. Right? So newborn infants sleep 18 hours a day, and 50% of it is REM. Now what's really amazing is they can go straight from being awake into REM sleep, and you see the eyes fluttering, and parents wonder about seizures, and it's not, it's just them entering REM sleep. Now, also the other feature is most infants sleep by 3 months of age. 25% have not slept through the night by 6 months of age. So you have to keep these rough parameters in your head when you're talking to parents with sleep disorders. Now, naps are common, and when you're not a parent, you don't know this, but most parents do know this. So naps, usually 2 naps per day till the first birthday, and then between 1 and 3 years of age, usually 1 nap, and it's given up by 3 years of age. Now, this is a challenge. What's not realized by most people is children frequently arouse at night and go back to sleep. Now, this study is interesting because you see what percentage of infants have awakenings at night. Certainly 25% of regular kids awake at night. Now, the reason why it's important to know this is, say the child awakes and the parents go in and interact with the child. It is promoting maintenance of staying awake. So hence a problem in nighttime. Now, all infants do this, and they just stay quiet in the crib and go back to sleep. Breastfed infants awake more frequently at night, and 50% of nights. Right? 1 to 2 year olds, 20% awake, and then olders, a fair number awake at night, but they go back to sleep. So it is important to promote good sleep hygiene early. Now, you have to have strategies where you promote kids sleeping through the night from very early on. Now, so focus is on getting children to bed and then reducing nighttime feeding and not promoting interacting with children once they get asleep. Because we recognize that when kids get asleep, they do awake, and by interacting with them, we promote a lack of sleep maintenance. So, getting to the item that most parents fear is sudden infant death syndrome. It is a significant concern for most parents, and even there's good prevention strategies, but the underlying mechanisms are still being explored. Sudden infant death syndrome occurs under 1 year of age, 90% under the age of 6 months, and usually during the winter months. Now, I say there's no known cause, but that's probably not true. Certainly, instability of the vasomotor and respiratory system certainly is playing in. Now, other features is they have poor response to CO2 and inability to correct their airway when it's obstructed. And what we mean by this is if they're lying face down and their airway obstructs, they're not able to open their airway by turning aside. Now, we know this from many elegant studies from New Zealand, Europe, and here in North America, that known associated sleeping on tummy, and hence led to the back to sleep program. So this is particularly important to understand. Now, smokers in the house is a significant risk factor. Now that we have got most kids sleeping back to sleep, smokers is a concern. Now, temperature. Now, this has been certainly showed from a number of New Zealand studies where the temperature of the house being elevated at night can be an issue. So, it usually resolves, the risk is resolved by 1 year of age, and then you get into the classical sleep disorders. Now, just to talk about each one for a second, and just spend a little time with each. Bedtime struggles. Bedtime struggles are common throughout childhood. They've become particularly difficult in recent years, mainly because of TVs, video games, and computers in the bedroom. There's a lot of screen exposure that is reducing the will to go to sleep. Also, this bedtime struggles can even occur in infants who don't have these other items to keep them awake. And then we'll talk about parasomnias. Now, what is a parasomnia? Now, the best way to think about parasomnia is a sleep behavior. They can be particularly impressive. They usually occur with a background history, a family history. Now, when we need background, what are they? They're items like sleepwalking, night terrors. These are what we're talking about. Now, they usually occur, and particularly night terrors, occur in deep REM sleep, known now as stage 3. They're common in childhood, decrease with age, and they do persist, some persist into adulthood. This does not mean there's a psychopathology. Now, features that induce these behaviors is fever, sleep deprivation, and certain medications. And for example, we can actually see sleep talking and night terrors reoccurring when kids study for exams many years after they seem to resolve. So stress and sleep deprivation are significantly inducing these events. Now, what each one? Let's talk about each one. The prevalence. Sleepwalking, about 10% is a good number. Now, about 25% persist. Sleep talking is really common. Sleep talking is common, 50 to 60%. Night terrors, they're quite common as well, quite common. Restless leg syndrome, we used not think that this was particularly common. What we mean by restless leg syndrome is inability to get comfortable while going to sleep, wish to move all the time, and this is really quite common, more common than we ever thought. And then enuresis, classically known to us, and bruxism, quite common and also persists. Well, the night terrors, and with Halloween approaching, this is probably a good picture to show. Now, this is extremely common. Kids were up scared. 2/3 of all kids experience them. They're very common in preschoolers. Parents worry about them a lot because they're very, very vivid. They occur in REM sleep. Now, what we learned about REM sleep is later in the night. Now, we adults can rationalize them, and we believe them to be not real, but children can believe the night terrors to be absolutely real. Night terrors, and I mean nightmares. Now let's go back to night terrors and how do they differentiate from nightmares. Night terrors are common as well. They start between 2 and 4, and the first time they happen to a child, they're very scary to parents, and they usually resolve spontaneously. There's an increased family history of enuresis, sleepwalking in first-degree relatives. Now, these ones, as opposed to nightmares, occur in stage 3. Now, they occur in the first half of the night, and usually they happen about 9 or 10 o'clock in the evening. Now, what happens is, and when you see them, they're quite scary, and they're hard to believe they're not seizures. The child will sit bolt upright, staring, appeared frightened, screams and cries, but does not seem to be hurt by them. There's autonomic arousal, which means sweating, and it lasts up to 10 minutes. And then the child goes back to bed, totally unaware of the whole lot, and goes back to sleep. Simply, no recall whatsoever. Now, there's no association with psychological problems. Now, it does happen in the adult world where they see it, and it's usually post-traumatic stress syndrome or panic disorders they're seen associated. And indeed, there's descriptions of similar types in REM in post-traumatic stress syndrome. Now, if they're very disruptive and occur daily, we could try benzodiazepines at night. We do not recommend this because they're usually not that disruptive. And sometimes can be a manifestation of seizures. That is only partially true. It probably means that a night terror is being confused for a seizure and really wasn't a night terror to start with. Now, these are the things from a pediatrician's point of view to look at. Why, and the parents come in and explain these frightening events, and one has to decipher which group are you in. So nightmares and night terrors. So nightmares, certainly in the early group, certainly in the same age group. Nightmares are late at night in REM sleep. Night terrors are early in the night, about 9 p.m. In non-REM sleep, stage 3. So late in the night, 3 a.m., and then early in the night, 9 p.m. Upset, scared, nightmares, upset and scared. And then in night terrors, they're just disorientated. They're not aware of their environment. Nightmares are completely consolable. Night terrors, these kids totally unaware who's around them, and anything you can do to console the child doesn't help. Now, nightmares, because they're scared and they have a vivid memory of the events, they find them hard to go back asleep. Night terrors, go back asleep, the following morning have no visions at all. Now, just to emphasize, all of these are normal childhood events, and they're not are common in pediatric practice. Now, bruxism, we hear more and more about it. It occurs in up to 88% of children to some degree, and it occurs in 20% of adults. It can occur in any stage of sleep, which is unique among these parasomnias. May result in damage to the teeth. They grind their teeth every 20-30 seconds, and malocclusion plays no role in bruxism. Sleep talking, really common. It occurs like bruxism in non-REM and REM sleep. Kids gradually grow out of this, and there's no treatment necessary. They don't sleep, they don't talk for very long, the conversations are brief, and certainly are non-intelligible. Now, sleepwalking I want to spend a few minutes on, because it's can have significant consequences. It's more than just walking around. They just don't get out. They actually can have simple behaviors or more complex behaviors go downstairs. Now, the reason why this is more important is because they can expose themselves to risk, like walking outside into a pool, or walking outside from an upstairs veranda and walking out. Now, the sleepwalking is slightly later. Tends to resolve spontaneously with adolescence. However, it does reoccur with stress, and some very tragic cases have been described. It occurs in 10% of children and 2.5% of adults. Usually, again, note this very positive family history. Stage 3, first third of the night is when it occurs. And it gets a bit like the night terrors. Now, there's these sleep motor phenomena, which we don't call parasomnias, we call them just motor phenomena. These are very well hypnic jerks, that's just jerks when you go to sleep, very common, very normal. Body rocking, very, very common. Not a huge problem, particularly seen in Down syndrome and some kids with autism, but very frequent outside of those two syndromes as well, and does not portray that you have one of those two syndromes. And in restless leg syndrome, something I want to talk a bit about, because it is really very, very common. Restless leg syndrome was quite frequently thought to be mainly an adult disease. And what you see is periodic leg movement and the inability to stay quiet and peaceful in one area. Now, just to focus on it, it's usually they cannot get comfortable going to sleep, toss and turn. And then what happens is that during REM sleep, they have periodic leg movements where they move their legs and limbs. It's more common in children than recognized, and maybe 40% have it. Now, we do see it in anemia. Most renal doctors know about it in pregnancy, which wouldn't apply to pediatrics, and then uremia, of course, and neuropathy. Now, anemia can be independent neuropathy, and indeed, it is now recognized that in some ways, restless leg syndrome is iron deficiency of the brain. Now, it is usually not the iron levels that help you, it is the total ferritin level. And when we usually we screen for it with a ferritin level. Now, the treatment for the vast majority of children is iron. Now, we do progress, if it's very severe, to a number of medications normally used for Parkinson's disease. However, we rarely use these because they have problems with tolerance, and when you come off the medications, there's a rebound. So it's very, very rare that we even consider using these medications. Now, just to give you they give you very elegant sleep studies, and I just want to show you an elegant sleep study. This is periodic limb movement, which is part of restless leg syndrome. And I just want to give you, now in this case, although I say occurring early on, you can see some eye movement here. So this is the EEG up here, eye movement here, and this is the chin here. But see the electrode is on the tibial, and see these periodic bursts of leg movement. So they're very elegant and easy to see on the sleep studies. Now, a more common problem for all of us, both as physicians and parents, is adolescent sleep patterns. Now, they're very, very important, and each teenager goes through them. And it certainly goes into college, and a lot of colleges have altered their college schedule, and a lot for people who have problems with it, later study times. Now, they're a public health issue because, a more public safety issue, because driving in the morning and a sleepy adolescent is not a particularly good idea. It also alters extracurricular activities, like if you do sports early in the morning, and then school start times. Now, indeed, most pulmonary sleep physicians do advocate for a later school start time for teenagers. And it has got, and the American Academy of Pediatrics pushes for this. Now, it is what we call, what is this phase that normal teenagers go through? Now, it's called delayed sleep phase. It is normal. However, there are some people who have truly pathological delayed sleep phase, and this persists into adulthood. Now, what happens is you go typically excessive daytime sleepiness, and the thing that cuts out is these kids go to bed at regular time and stay awake till 3, 4 a.m. in the morning, and would normally, left to their own devices, would get up at 3 and 4 p.m. Now, the patient complains of inability to get to sleep until early morning, and little difficulty sleeping once asleep. Very, very typical. Now, this is a very hard thing to deal with in teenagers, and generally you have to do the best you can, because school start times are still an issue. Now, what we do is the following: expose them to sunlight. Now, what he does, we'd have kids like this, and certainly in the summertime, which is not the main problem time, we tell them to leave their curtains open. We give them B12, which seems to be somehow promotes normal sleep, but we do give them melatonin. And the reason why we give them melatonin is it is worth giving them melatonin. It is certainly relatively non-toxic, and it's quite effective in resetting the clock to a little earlier. So we give them melatonin about 30 minutes before the desired going to sleep time. And we don't give particularly high doses because we're trying to just set the clock. Some people will give it 2 hours earlier. So it's just ultimately more about long-term issue, just to set the clock for a little earlier. Now, getting to the core feature that what most of us want to talk about and discuss in more detail is obstructive sleep apnea. What is obstructive sleep apnea? And why is it particularly common in pediatrics? And why should we be worried about it? These are important issues to go slowly and think them through. Now, it is classically defined as periodic apnea due to sleep-related airway obstruction. These things are common in pediatrics. And we'll go through each one in detail. Not all snorers have obstructive sleep apnea. And then the consequences of these can be daytime sleepiness. And even in children, it may not be daytime sleepiness, it might be hyperreactivity. And then long-term complications of pulmonary artery hypertension and right heart failure, which is not a particular problem in pediatrics. Now, why does the infant and child get obstructive sleep apnea more than the adult? And how is it different? Now, what's really interesting is the pediatric airway, the infant airway, take note, the jaw is further back. So it pushes the tongue back, the soft palate back, the airway is smaller. And then you get a little older, 2 or 3 years of age, you get these things called adenoids and tonsils, and they facilitate the obstruction of the airway. And then as you grow older, you see it just grows, everything moves forward, and the airway is better. So because of the pediatric airway structure, you're more likely to have a sleep-related issue. Now, this is classically done, the Lou study, and it just shows it in a more elegant form. And this is just to show a control infant. And the whitish gray here is the airway. And you see a beautiful airway here. And then you see the obstructive sleep apnea. See how it's more narrow. And then you see here tonsils in red. They're just bigger. And that's the main issue. So you can do these elegant studies, but they rarely need to be done. So you have to know basic features of what obstructive sleep apnea in childhood is. Now, it is very different towards the adult world. So we have a number of features. Everybody knows what apnea is. It means you stop breathing. Less people know what hypopnea is, and that means shallow breathing. And then the apnea-hypopnea index, and so on. Let's look at each one in detail. So what is apnea from a pulmonary sleep position point of view? It is a pause in respiration for more than 2 breaths. Now, the adult, criteria is based on a number of seconds, like 5 and 10 seconds. This is not what we do in pediatrics, because we breathe faster. Hypopnea means there's a reduce in airflow by 50% for 2 respiratory cycles, 2 breaths, accompanied by a 3% drop in O2 sat or an arousal from sleep. Now, these criteria vary every few years, but they're roughly true. And what's the index? Well, the index is the sum of both groups. So the number of apneas and hypopneas per hour. Now, the respiratory distress index is not something to focus on too much. It's just something like where you have enough respiratory distress that does not decrease the flow of air very much, but wakes you up. So these are respiratory distress events, and what we do is we combine the apnea, hypopnea, and respiratory distress events, and they may be a better reflection of true obstructive sleep apnea in pediatrics. Now, what do we regard as obstructive sleep apnea? Greater than 2 events per hour is most often used as the criteria for obstructive sleep apnea. Now, some laboratories use 1, and they probably classify apnea more strictly. Now, in the adult world, obstructive sleep apnea is greater than 5 events per hour. Now, what is amazing in pediatrics is the pediatric patient is, although can have significant obstructive sleep apnea, preserve sleep architecture, as adults tend to lose sleep architecture, namely, they lose REM sleep. Now, there's frank sleep apnea, and there's a number of grades in between. Now, let's just go through each one. We have sleep disorder breathing events. Now, what are they? There's primary snoring, and then we have obstructive hypoventilation, upper airway resistance syndrome, and obstructive sleep apnea. Now, this one we are all familiar with. Now, what's primary snoring? That means you snore, but it's not altering your sleep, giving you apnea, or giving you arousals. Now, obstructive hypoventilation. Now, this is something quite different, and what this means is that partial upper airway obstruction, you might not see it as frank apnea, but you see alteration in the gas exchange. And then you have upper airway resistance syndrome, and this is a bit like what I was describing to you, where you have the upper airway obstruction, which causes you to arouse from sleep. And then the frank obstructive sleep apnea, which is characterized by apnea, disruption of ventilation, but disrupts normal sleep patterns, but you have to be very severe in pediatrics to disrupt normal sleep patterns. Now, just to give you an idea, this is what it looks to me, a sleep physician, looking at a polysomnogram, and this is what a polysomnogram looks like. And just to look at, you see the heart rate running across here, you see nasal pressure here. Now, what nasal pressure here means, that's a surrogate for airway flow. And then you see here, this is chest wall movement, and we'll talk about this is the summation of chest wall movement, and we'll talk about all of these in a second. This is oximetry here. Now watch what happens. So let's look at this one. Central apnea. What is central apnea? Central apnea? No. There's no effort. See? There's no effort. So this is chest, abdomen, and some. Chest, abdomen, some. So the chest doesn't move, the abdomen doesn't move. Hence, you got no effort, so this is regarded as central apnea. No flow. Now, these are obstructive apneas here. Now, what are obstructive apneas? This means that the air doesn't flow, but you're trying to take a breath in. And what you see here is there's no flow, but here you are trying to take a breath in. Here you are trying to take a breath in. Now here's one over here. This is partial flow. Now, but partial flow to you and me means hypopnea. Remember, went down by 50%, and you see the jumps in airflow here. Now, this is a particularly florid example, but they're usually not this easy. And you see the wall movement here. And most hypopneas are variation of obstructive sleep apnea. So we see, and this is what we're focusing on when we read them. Now, I just want to point out these things are EEGs here, and these are arousals. Now, just I'll flick through everything here for a second. Now, let's go back and look at each one of these in detail. Now, here we have looking at all the various diagnoses. I'm just going through them. The diagnosis: primary snoring, upper airway resistance syndrome, obstructive hypoventilation, and then these are the classical obstructive sleep apneas. And these two here are variations of these. Okay, now let's just focus on a second. So primary snorer, just snores and no apnea, less than 2, and in our lab it would be less, in the other labs it would be less than 1 for an apnea-hypopnea index. Now, there's nothing wrong with the O2 sats. The nadir is always, the lowest number is always greater than 92. The entitled CO2 does not particularly go up. And they have, most kids have microarousals, and they don't have elevated microarousals. Now, the upper airway resistance, well, this one is, it's sort of, you have to have increased respiratory effort to breathe, but you don't have frank apnea. And look at what happens here. Now, and you don't alter oxygenation that much because you're sensitive and you sort of stimulate yourself to wake and improve oxygenation. So here you have upper airway resistance. You see the apnea-hypopnea index is normal. You see the O2 sat here is really unaffected, but look at the arousals. So what you do is you start tugging to improve your airway performance, and you wake yourself, these microarousals. Now, obstructive hypoventilation, what that is you sort of have low-grade airflow because you're partially obstructed. And watch what happens here. Now, what happens here is you don't have frank apnea, but you have gas exchange problems. Your O2 sat's going to be low, your CO2 is high, and you wake yourself up all the time. Now, it's easy for you and I to understand obstructive sleep apnea because these are just the classical apneas that you and I understand. We give them nice numbers. And the mild would be an apnea-hypopnea index in our lab 2 to 5, and in other labs 1 to 5. And what you see is you get drops in O2 sat, CO2 is elevated, and then you see over here you've got these arousals. Now in moderate, you see the apnea-hypopnea index goes up. You get more of these sats, 76 to 85. And in severe, you can see down to 75. And you're amazed how tolerant these kids are. So these are all gradations thereof. And now, and then you and I have to figure out why. I want to thank Elliot Katz for this slide. Now what happens is the obstruction can be anywhere. Now this is the first one. The obstruction can be in the nose. Here's the nose. And what's the most common cause of obstruction in the nose? Allergic rhinitis. So hence you would treat the allergic rhinitis. Now, another common is upper airway obstruction. That's palate, high arch palate type structure. Now, the reason why it's important to focus on this is it offers us opportunities to fix by orthodontics. So very, very important to look at this. Now, and then you can do it with a palate expander, and as me, a sleep physician, we use a lot of palate expanders. Now, this is looking at the back of the airway. This is looking up here, and these are the adenoids sitting here. So adenoid problems can be a problem. And this is classically is enlarged tonsils. Now, most people, when they think of obstructive sleep apnea, think of enlarged tonsils. But certainly these, and certainly are by far the most common, them and adenoids are quite common, but these are important, really, these two up here are very, very important considerations. Now, why do we care about obstructive sleep apnea? I said they're quite tolerant. It's an issue we shouldn't focus on too much, maybe not. But a lot of studies show that it's a significant problem. And generally, a lot of us, it doesn't, having significant obstructive sleep apnea in childhood affects a number of systems. Now, this is a study that I find quite compelling. This is looking at blood pressure with sleep disorder breathing. Now, they looked at a cohort of 700 children from kindergarten to 5th grade, and they looked at blood pressure. Now, blood pressure, once this is diastolic, this direction, this is systolic, diastolic, and then mean. Now, all you have to take away from this slide is, see the apnea-hypopnea index as it gradually rises, see? The blood pressure goes up. So if we assume that blood pressure rises in childhood and persistence in blood pressure means persistence in adulthood, this has particular implications for the adult population. Now, this study I put up not because it is the most elegant study, but it shows it quite well. It shows that poor sleep performance, in this case benign study, even primary snoring, where it just looked at primary snoring, which is a mixture of primary snoring, obstructive sleep apnea, and then they looked at performance. They looked at performance in the class. So they did have this simple study where they looked at severity of snoring. Just take a look. So mild snoring, were you more likely to be in the lower part of your class, the low performance, or the high performance in your class? Zero snoring, right? You're more likely to be in the high performance. But look what happens. As you snore more, you're more likely to be in the lower performance. Now, does this mean that people who have lower performance in school have something wrong that gives them the low performance, or is the low performance contributing? Most of us believe that it is the poor performance in sleep that results in the poor performance in school. Now, this study is a Chevron study, has been followed up. Now, and what they did here was they did, as I said earlier, the most common cause of obstructive sleep apnea in pediatrics is tonsils and adenoids. And what they did was they treated them, they treated various groups, and you see the control group not treated, right? And then you see the orange group, which is the post-tonsillectomy, and then the pink group is tonsillectomy, we'd always say. And just thinking, what happens? So there's sort of a control here for a tonsillectomy with no RCA, and then there's a true affected group where you have obstructive sleep apnea and had a tonsillectomy. So watch what happens. So here you see that and these are a number of things, age-based hypopnea, and then cognitive behavior. And this is what I find particularly interesting. You see all groups have an improvement in cognitive behavior, but the pink group, which are starting lower, see how they're starting lower? The starting lower here, they improve. They improve. Now, the thing that just jumps out a little bit from the study here is the pink, see this more, which call these various groups, the orange and the more pink groups, anyone who have some degree of obstructive sleep apnea tend to improve. Now, the data is dirty, but it certainly seems to suggest it. Now, I just wanted to focus on so generally what we believe at this moment in time is poor sleep from obstructive sleep apnea decreases school performance, can affect blood pressure, and has developmental effects. Now, so this is what is the standard of therapy? Okay. Now, and this is an earlier study we're to look at, but what it shows is all children showed improve in respiratory parameters after surgery. And this is true. Most of us believe that about 30% have reoccurrence of symptoms or incomplete resolution. So at this moment in time, if you start out with very severe obstructive sleep apnea, an adenotonsillectomy is the initial therapy, unless there are other obvious reasons for therapy. And what we do is we focus on this first, and if they have very severe obstructive sleep apnea, what we tend to do is repeat the sleep study just to make sure it went away. Now, 82% had resolution. Now, a problem that's come up for us in recent years is effectively with the mild obstructive sleep apnea. What do you do with mild obstructive sleep apnea? Should you go ahead and take the tonsils out early, or should you just wait and see? Now, this study's worth a little bit of a look. It's from more than a look. It's very recent in 2013. And what it did was it put two groups, sort of watchful waiting and early tonsillectomy. Now, I don't want you to focus too much on each group, but what I want to point out is, say, they looked at primary neurocognitive outcomes, and this first slide demonstrates it. They just watchfully waited, right? They just watched them when baseline change. Now, change from baseline, not much. Early adenotonsillectomy, there was an improvement, but not significantly greater than those with watchful waiting. Now, this has put us up in a very unusual situation at this moment in time, is to say, in these milder obstructive sleep apnea, and what I mean by milder, with an apnea-hypopnea index greater than 5, should you go to early tonsillectomy or should you do waitful watching? It really depends where you are. We are in the waitful watching. If you don't have to do something, you don't need to do so. Generally, we're less tolerant of being a waitful watcher if they have significant issues related to neurocognitive function. So at this moment in time, I think the way the practice is going is that waitful watching in a child who has normal neurocognitive and behavioral function is the way to go. And then early tonsillectomies is somebody who has hyperactive or some signs of poor school performance, then we would go with earlier intervention. Now, we're seeing at this moment in time a significant number of children who, even despite adenotonsillectomy, have significant problems. So when you come to the sleep study, I said the thing we do focus on looking at your upper airway. And now, but this is somebody with a high arch palate, and watch what the palate expander does. Pushes it out, and increases airway size. Now, we are focusing on this as a second line of therapy if it's applicable to a child, mainly because the fix can be permanent. And hence, it gets over chronic therapies like CPAP. Now, let me just take a look, and this is, I think, one of the more elegant studies done in this area. So, you know, these are T0 position, T1, that means push it out a little more, C2. And I just wanted to look at the apnea-hypopnea index. Here's the apnea-hypopnea index. So, up here, high arch palate, 12. And most of us would say that's certainly severe apnea, but watch what happens. When you go out and expand it, it goes down to 0.4. And certainly, if you have the right type of palate and you have left with obstructive sleep apnea, despite a tonsillectomy, this is the way to go. Now, say that, and these are sort of classical features, and when you come into the sleep clinic, we're looking for this high arch palate, long face, because we greet it because we feel there's a simple way of treating this. Now, the other surgical thing that we focus on some children, and I want to bring it up early because and you notice I'm coming to the usual therapy last. So it's called mandibular distraction. Now, mandibular distraction can be used for sweet obstructive sleep apnea, and actually effectively what you're doing is you're pulling the jaw gradually forward. So and that because you pulled it here, you pull the tongue forward, hence you open up the airway. Now, this is very effective, but it is really, you only use it, certainly use it in syndromes, in a syndrome type picture. Now, I just want to show you, this is a group of patients who have very severe obstructive sleep apnea and belong to the Pierre Robin sequence, which really to you means a very small jaw, which is pushing the tongue backwards. Now, what they did was took a large cohort, right? And what they found was even when the jaw was pushed back and then they advanced it, and these kids can have very severe airway obstruction and have to have a trachea, and with distraction forward, they found that there was a very good improvement. 74% were decannulated, and 100% of adults was cured of the symptoms. Now, so what we're seeing is a more progression into the surgical. Now, why are we so generally this is not how most pediatricians think, because of this. We classically think in pediatrics, and this is still the standard practice, and what I want you to take away from this, is that what we do is if we see obstructive sleep apnea, what we do is we do an adenotonsillectomy. If that improves the child, we think it's wonderful. If there are persistent problems thereafter, we go to CPAP or BiPAP. Now, these are elegant and are very, very effective. The problem with CPAP and BiPAP is the compliance and the long-term maintenance of CPAP and BiPAP for life is a challenge. So hence, although very, very effective, we are looking at more long-term corrective procedures more frequently now. So the natural progression is look for obstructed airway disease related to allergic rhinitis and large tonsils and adenoids. Take that out of the picture, and then look if you have persistent obstructive sleep apnea, then look for other fixable items. Maybe not go through a jaw advancement, but mainly go to, certainly consider pallet expanders, and then go to CPAP. Now, we're seeing more and more obstructive sleep apnea, and you could not have a sleep study, a sleep talk without obesity. We're just seeing more and more. And the main reason for this is the deposition of fat in the pharyngeal area and soft palate. And also, we're seeing increased weight on the chest, which decreases lung volumes. So lower lung volumes, lower reserve, you don't need much to decrease flow. Now, so just to see, can we remember, and I wanted to focus on this, on the parasomnias. Which of the following is true? And I give the answer straight up, but sleepwalking occurs in about 10% of children and is likely to persist into adulthood. That is true. Night terrors occur late in night during REM sleep. That's false. Nightmares occur in REM sleep. Now, a good way to remember this is the reason why you're paralyzed in REM sleep is because you don't want to act out your nightmares. Now, nightmares occur in REM sleep and a child has no memory of them. That's false too, because they do occur in REM sleep, but they remember them. Remember, these are the kids who wake up and you cannot put them back to sleep. And Bruxism is common and rarely persistent in animals. It's also false. You find Bruxism is really common, up to 88% of kids and 25% of